it move? It moves back and forth. And Swapnajit, it does move, does it? Sometimes it gets stuck. It is moving back and forth, is it?
Yeah, sure.
Okay. So, colleagues, it's fantastic to meet with you, and Cam and I are really looking forward to just having some thinking with you and hopefully taking some of this work forward with you. So thank you very much for the invitation. Particularly thanks to our colleagues at Chandigarh. Swapnajit, thank you so much. You've done so much organizing for this. And thanks to Professor Basu as well. Thanks to colleagues in the UK, Farid Uma, who's partly based in our service and has helped to organize. And of course, Cam Bhui, who's my longtime companion in thought. And it's been, so just to thank all these colleagues. Now, let's start off with what are the limitations of this workshop. And a lot of what I'm going to say has been captured by what Cam has said. If we think what might be the difficulty of this training, let's acknowledge our patients are difficult. You know, patients are difficult, but so are psychiatric patients. And then even more difficult are our patients with personality disorder. And then our discipline, being a psychiatrist or working psychotherapy is difficult as well. It's not an easy occupation. And then as Cam has alluded to, the context in which we work is difficult. Our resources, our services are not working under a lot of with a lot of equipment and training and staffing. So it's really difficult what we are having to, the situation in which we work. And then let's also acknowledge, and again, we are difficult because we're human beings. In other words, how we feel when we have difficulties in the encounter with the patient is also something that we may contribute to the difficulty in the situation. So let's acknowledge that, you know, we're all humans, our patients are humans, so are we, and therefore the whole situation is quite a complex one, really. It's two human beings being in the room. Two human beings in the room is difficult. The other limitation of the format is that it's limited time in terms of what we wanted to get across. Is a wealth of information and experience. And so clearly we can only do so much in the time we have. And then the format that we are, you know, it's fantastic that we can meet in this way, but let's acknowledge the limitation, the fact that we're not in the room. I can't see you, I can't see where you are as a group. So given these limitations, what I suggest is, as participants, colleagues, you've had a busy week. I encourage you just to sit back and enjoy what Cam and I have prepared in an open-minded way. Just listen to the narrative. It's impossible to take in all the details, so just try to get the main principles, the main flow of what we're trying to get across. And the nature of this is an intellectual clinical inquiry. In other words, we very much encourage you to bring in your questions. What we're not doing is trying to say, this is the method, or, you know, we're certainly not trying to teach in any kind of religious way. We are wanting to work as clinical scientists. In other words, please, if you have questions, you are so welcome to bring them in. In fact, some of the questions are the best ways for us to learn. If you ask a question that we don't know, that pushes us. So very much encourage that we enter into this seminar in a way which we willing to interrogate the claims and the information. So that's your role. And my role as a lecturer is to introduce you to the main applied aspects of transference-focused psychotherapy, and to try to do it as it's relevant to you in your setting. And clearly, you will help me by reminding me at times of what might be particular aspects or limitations in which you work. So what I've just done is I've set up a contract. Now, the reason why I've set up a contract because I've said, look, colleagues, I'm inviting that your role is to be open-minded, to be in a state of inquiry. And I've said that my role is to try to teach as much as I can within the limitations of my ability and the time that we have. That's the contract. Now, the reason why I'm stating it so much is that, in essence, I've already taught you some aspects about transference-focused psychotherapy, because in TFP, there's an emphasis placed on the frame in which the service is or the treatment is delivered. So in the same way that I'm doing a teaching now, I'm set up a contract. In the same way, I encourage you to think of your work with the patient as in some way setting up a frame as much as one is able to in the very acute setting of psychiatry. So I've just given an example of an important principle of TFP. So the objective of the seminar is to better prepare you for working with, and we're emphasizing borderline personality disordered patients. And the lecture part of it is, part one is the what. I'll be just outlining the main aspects of TFP. Part two is the why. Why would we be saying TFP is a useful approach for psychiatrists? So we'll be backing it up with some claims about why it's a useful approach. And then part three will be the how. How do you actually, in your busy work as psychiatrists, try to apply principles of TFP in your work? And as Swapnajit has said, we will then test what we've said through a role play and debrief, and hopefully have some rich discussion following from that. So I'm going now on to the part one of the lecture, which is the what. What is TFP? Now, TFP is, and this is why I think it's useful for us as psychiatrists, that it's a structural and a structured approach to personality disorder. Now, I think we as psychiatrists will take to this way of thinking. When I say it's a structural way to understand personality. Personality is so complex that if one starts thinking about the structures of personality, it helps to orientate oneself in a very complex concept. What is personality? And then it's a structured approach. And again, this is what the contribution is to our work as psychiatrists, because it's structured. Now, it's an evidence-based approach. It's been manualized. And again, that's what's useful about it, that there's been an attempt to operationalize some of the concepts. It's for individual outpatient therapy. And let me say that this is a dated definition, because we are now moving to group therapy as well. And it's aimed for serious personality disorder. So the background to TFP is that it was invented or developed by Otto Kernberg, who is still alive. Otto is now about 94, but he's one of the most famous psychoanalysts practicing. And Professor Kernberg started working with serious personality disorder, and his training is both as a psychiatrist and a psychoanalyst. And he could see that the way that the classical analytic approach wasn't working for severe personality disorder. So the way that you can think about TFP is an analytic approach, which has been specifically modified for the clinical condition. In this case, the clinical condition is severe personality disorder. Now, what we are doing in this seminar is we're saying, and this is not just us, but it's over the last few years, we've thought we can also apply not just a psychotherapy, but we can apply the principles of TFP to our work in general psychiatric settings, which is why we're so interested in meeting with your group to see what might be the application of this already evidence-based psychotherapy model in a wider setting, including in wider psychiatric settings. So remember I said that it's a structural approach. Now, when I say it's a structural approach, if you think about how difficult personality is to understand, then it's useful to start thinking of what are the dimensions of personality, which are the most important ones. And this we would propose are very useful ways to think about personality disorder. What's the person's sense of identity? What kind of defense mechanisms do they use? What's their ability to be in touch with reality? What is the quality of their object relations? And I'll go into a definition of object relations because it's a funny term, but in fact, it's not that complex. I'll go into that. How aggressive are they? And what is their level of moral functioning? Now, I would suggest that if you think of any of your patients and if you start thinking about your patients within these dimensions, it's a very useful way to start thinking about their personality. Now, if there's one slide that you take out of this seminar, then this is a useful slide or the useful slide. This is, again, Otto Kernberg's thinking. And what he does very usefully for us, he starts thinking both as a psychoanalyst and as a psychiatrist, because what he's done over here is he's thought about personality, and on the y-axis over here, he's placing them along levels of personality organization. And it's incredibly important if you can start thinking about the patient in front of you and where do they fit in terms of their level of personality organization. In other words, how severely disordered is their personality? It orientates you. It starts giving you a map. This is what this slide is. It's a map for you. It's a map for psychiatrists. So clearly, we have if we're going down the list, we're going from neurotic, someone who's neurotic. Well, I suppose on top of that, we can put a healthy personality organization. But then one step down is a neurotic. And then he's got borderline personality organization. And I stress organization, not disorder, organization, because the brilliance of this conceptualization is that by thinking of borderline personality organization, he then places what we as psychiatrists think of borderline personality disorder, antisocial, histrionic, narcissism. He places them all within this category of borderline personality organization. Now, how many times, colleagues, have you been in meetings with your teams where there's been, sort of debates, oh, this patient's borderline, no, this patient's narcissistic, no, they're histrionic. This is a way that we can understand why we keep on having these, even amongst ourselves. We have the debate amongst ourselves, see the patient one time, another time we start changing our diagnosis. This slide captures why that is, because in fact, there are underlying similarities in all these different attempts by psychiatrists to make a categorical diagnosis. And that similarity is because they all fit within a borderline personality organization. And a way to think about borderline personality organization is a lack of ability to have a clear identity, a coherent sense of self. And then going back to the levels of personality organization, the most severe level of organization is when the patient is psychotic. Now, the other points to take from this is you can see that here are the boxes, and that's how we think as psychiatrists. And you can see that by placing arrows, we're now thinking more as psychotherapists or psychologists, that in reality, life isn't a box. In reality, personality is a dimensional concept. So you can see that this is captured by these arrows. And again, if you understand the meaning of the slide, then you will realize why, for example, narcissism is such a difficult condition, because you can see over here, it goes over a very long range. You get very high functioning narcissists, and you get narcissists that are functioning at a very low level. The other point I want to really emphasize is that there's a concept called malignant narcissism, where the patients have a combination of being paranoid, antisocial, and very aggressive. I'm saying this because, colleagues, if you have a patient who you think has a personality disorder and has those qualities, be very, very cautious in your work with them. Those are the main aspects, but really, this is such a useful slide to organize you in your clinical work with your patients. Now, when we think about TFP, again, thinking about the structure of personality, in a way, the basic unit, the most underlying unit of personality, we would think of as being the object relations dyad. Now, it's a funny term, object relations. So let me just unpack it for you in a way which is very easy. If I say the word mother, I think that hopefully for each of you, you would have had an image of your mother, of a loving mother, and an image of yourself, maybe, at the age you are now or as a young child. I've just, in that process, explained to you what an object relations is. In other words, it's a self-representation. So when I say the word mother, hopefully your representation is of yourself as a loved child, and your representation of your mother as a caring person. And the affect which binds them is hopefully one of love. That's in a simple way, a way to understand object relations dyad. It's a psychic representation of self. It's a psychic representation of the other, bound by an affect. They don't float around in unconnected ways. It's absolutely bound by some emotion that you have between your self-representation and your representation of other. Now, remember I said TFP is a structural approach, and I've just gone through the structural approach. Now I'm going on to explaining why we say it's a structured approach. It's a structured approach because it's very, very specific in the way that it approaches the clinical work. It thinks of strategies. What are the long-term objectives of the work? What are the tactics? And what are the techniques? The techniques are what do you do in the actual encounter with the patient? So just to say about TFP that it's, I think it's something in what Cam and I have said, that our aim in meeting with you as colleagues is to advance our clinical thinking and advance science. Our aim isn't to push a particular model. What we just be doing today is to discuss TFP because it's a useful model. And so when I put up this slide, it's not say, oh, just join this organization. What I'm saying is it's an organization which has the qualities which I think are consistent with why we're meeting with you, which is it's an organization which wants to advance good clinical thinking and an organization which is committed to research as well. Just to say, that's Otto over here, Otto Kernberg. This was a few years ago, and he's a very productive thinker and still presently is a very senior member of our organization. And to say that this is the International Society of TFP World Map. And again, the reason why Cam and I are so pleased to be meeting with you as colleagues is that you can see that India isn't on the map. So in some ways, this meeting is putting India on the map. And when I spoke to our president, Frank Yeomans, he was saying he's very pleased that we are meeting with colleagues in India because it hasn't been an area that we've managed to bring discussions about TFP in yet. So now I've done the part one, which is what is, just a brief introduction to TFP. So now I'm going to part two, which is why. Why would we endorse TFP? And I'm going to give reasons based on recent developments in neuroscience, what the evidence base is, to actually say that ICD-11 really endorses what TFP has been saying for years. So again, it's very useful that given ICD-11 is now what we are going to be needing to use, that we've now got a clinical approach which is very consistent with it. So in terms of the neuroscience, if we think about it, we as psychiatrists, our whole job really is working with patients' feelings. And so it makes sense that we really draw from developments and our knowledge in affective neuroscience. And if we then link it to TFP's origins, which, as I've said, that TFP would consider itself as a modified psychoanalytic treatment, then we can start linking to Freud's concept of the two main drives, but then bring it into modern day science, where in fact now we realize there aren't two, there are far more than two, and one of the main models of the brain accepted quite, very widely is that developed by Panksepp, who describes not two, but 7 emotional drives. Now, these are the drives that Panksepp describes. Seeking, we need to go out in the world and forage. We are interested, in a way, being in this seminar is you doing seeking. You are seeking for new knowledge. You are seeking to be better clinicians. That's a seeking drive. There's the drive of lust. We all need to find sexual partners. There's the drive to care. We need to care. If there's a child, even if we don't know the child's upset, instinctively we want to look after that child. There's the panic grief system, and that's really the attachment drive, that we need to attach to others. The one about play is a very interesting one, and that is we have a need to be in a social system, and how do we organize ourselves within the social system? In other words, the ability to relate to another person in a way which is has elements of interacting in a way which is mutually satisfying is a very complex aspect of us as human beings. There's the drive of rage, that we want to just, if someone's in our way, that the drive is to destroy that or to get rid of that frustrating object. And clearly, if something is making us scared, we want to escape. Now, the reason why this is important, colleagues, if you look at these emotional drives, inherently there's an object in them. In other words, for example, in terms of lust, we need an object. We need to find another person. In terms of care, we want to care for another person. So you can see that while we talk about primary emotional drives, it's inherently object relations relevant. And these primary emotional systems have been well described in terms of the anatomy and the physiology and the neuromodulators involved in each of them as reasonably distinct emotional systems. Now, the reason just for putting this up is to emphasize that the main the most powerful aspect, and I think we would all experience this ourselves, if we're feeling very strongly about having a very strong emotion, it's very difficult for us to think clearly. In other words, what this is showing or demonstrating is that the primary process emotions are really very, very determinant in how humans operate. That the ability of top-down regulation of the cortex to actually manage is limited. Again, it pulls to the importance of affect and therefore pulls to the relevance of transference-focused psychotherapy, which is very focused on affect. Again, to note that Mark Soames, who is a South African psychologist and psychoanalyst, has taken Panksepp's work and really thought about the clinical implications of, for example, the fact that we have 7 emotional systems, not just 2. Can you see the relevance of this? Because if you start thinking of affect, and if one starts thinking, what is the function of affect? Now, this isn't just Soames's work, but it was initially the work of Antonio Damasio. But the thinking is the reason why we have affect is it's a signal from our bodies that there's some need, some basic emotional need. Remember, these are the needs that I've described. But if we have an affect, it's a signal that one of these or more of these emotional needs are not being met. Now, that has huge significance for us as psychiatrists, because when the patient says, I feel anxious, or I feel depressed, or I feel like killing myself, then the way that we can orientate ourselves, start thinking the patient is having this feeling. The feeling is not diagnostic, but it's a signal of some unmet emotional need. Now, I think that's got huge implications for how we as psychiatrists think about the interaction with the patient. And again, this is work that we've taken further with Mark Soames, where we've tried to think of, given this is a way to start thinking about the function of affect, the biological function of affect, how might it help us in our work with thinking about patients with personality disorder? So I'm now going to part 2. Why would we think TFP is a useful model for us to use? So TFP is one of the evidence-based treatments. And again, in the spirit of wanting to develop our clinical thinking, our work as clinical scientists, it's absolutely to acknowledge and respect all the evidence-based approaches. TFP is just one of them, and to respect and acknowledge the other approaches, and there might be colleagues that have had trainings amongst you or interested to really acknowledge dialectical behavioral therapy, mentalization-based treatment, and general psychiatric management. There's been 3 randomized controlled trials which have shown the efficacy of transference-focused psychotherapy. And again, this is an interesting study which where based on imaging, what the imaging found, so they imaged patients pre and post a TFP intervention, and the findings are consistent with what we'd expect, that the post-TFP treatment, there's upregulation of the prefrontal cortex, and post-treatment, there's downregulation of the limbic system. So if we think of those functions of the brain in terms of the prefrontal cortex, helping us to think through and manage and control and inhibit our some of our impulses, one can then see that the evidence for TFP or successful interventions can be shown through imaging. So now I'm going on to the third reason why we think TFP is useful, and that is because it's consistent with recent developments in ICD-11. So if we think of ICD-11, what are the steps that that ICD-11 guidelines recommend that we need to take in personality disorder? The first step is to identify if personality disorder is present, yes or no. That's the first step. Now, you can see that the way that ICD-11 has suggested that we make that decision when they say it's based on self and interpersonal functioning. We in TFP were delighted with that because you can see that ICD-11 is starting to think in an object relations way. They're talking about self and interpersonal, in other words, the other. So ICD-11 has embraced an object relations approach. And then the second point that ICD-11 suggests is that we look at the level of severity. Now, if I take you back to this slide, you can see that's what we in TFP have been saying for years. We need to look at the level of severity. Is it neurotic? Is it a high or low level borderline personality organization, or is it psychotic? These are the levels of severity now captured within ICD-11. And ICD-11 also recommends that one looks at the predominant traits. This was basically to just a slide saying how ICD-11 suggests that we assess the level of severity of personality disorder. And this is just to say that although there hasn't been enough evidence to support the pragmatic use of ICD-11, we can say that it has got some both clinical and scientific reasons to think that it's a good move to move towards ICD-11. One of which includes that it emphasizes level of severity. And that we think has both been research which has shown that level of severity has a predictive and prognostic value. And it's also how we think as clinicians. We think what should I do management based on the level of severity. So now I'm going on to part 3, and that's the how. How do we apply TFP clinically? So we'll come back to this. This is the clinical vignette that I'll use to take some of the, to try to put some of the theory into flesh, as it were. So I'll come back to this. And this is just to remind colleagues about the diagnostic criteria for borderline personality disorder. DSM-5 maps it out reasonably clearly. And in fact, the ICD-11 adopts the DSM-5 way of defining it. So if you want a shorthand way to think about how do you diagnose personality disorder, I think the most systematic way to do it is think of cognition, affect, behavior, and interpersonal relations. And under each of those domains, to then think of the criteria which are necessary to make the diagnosis as recommended by DSM-5. So under cognition, it's person's sense of identity. What's their level of paranoia or dissociation? In terms of affect, how unstable. And when I say unstable, I mean unstable as in a roller coaster of emotions over the course of 24 hours. I don't mean, so what I'm saying is it's possible to make a distinction between borderline personality disorder and bipolar affective disorder, and also rapid cycling disorder. borderline personality disorder, in terms of instability, is different. It's a different quality because the instability it's like this. It's very unstable. In terms of affect, sense of emptiness, and sense of anger. In terms of behavior, there's impulsivity and self-harm. And interpersonally, there's the fear of abandonment and very unstable emotions. I just want to briefly mention narcissistic personality disorder because although this lecture is mainly on borderline personality disorder, it's just to acknowledge that this is a very, very difficult condition which we as psychiatrists also are faced with. Just to note the DSM-5 criteria for narcissistic personality disorder. And the difficulty with this diagnosis, so this is a good set of criteria, but the difficulty with it is that it misses, it's only a partial capture. That when DSM-5 described narcissism, what they did is they only captured a certain phenotype of narcissism, which is the more thick-skinned or the oblivious. So you can see that what it misses out is the narcissist who's more thin-skinned or vulnerable. I'm putting this up as a slide just so that colleagues just be careful that if someone isn't obviously narcissistic, no, it's not obviously thick-skinned, they may be narcissistic, but it might be missed because it's a more thin-skinned, more covert form of narcissism. If we want to go to narcissism, that would be another whole seminar. So I just wanted to quickly name check it. So coming back to TFP, and a reminder that we've said that TFP is a structural understanding of personality and a structured approach to working with personality disorder. And a reminder that the structural approach is thinking about these domains of personality. And the structured approach is to think of the level of personality organization. Now, this just shows, and this slide is very full. I more want you to, again, I'm encouraging you to just listen to the narrative, to not get too lost in the details of the slide. The point that this slide is making is that by having a sense of what the level of personality organization is, that's the y-axis, and if one then puts in the rows, what are the main domains of personality that we're interested in, one then starts being able to think in a far more specific way about the personality disorder or the kind of personality of the person that you're working with. So I just really want to get that concept across of the usefulness of thinking of levels of personality organization and thinking about what are the domains of personality that you're interested in. And similarly, if you think of the levels of personality organization, it helps us as clinicians because it helps us to think about, for example, what's the prognosis? That we would expect the prognosis of someone in treatment with neurosis to be far better than someone with a low level of personality organization. The other important thing I just want to pull out from this is what's the level of structure needed. If any of you have been in therapy yourselves, probably your therapist or your analyst didn't spend ages saying, look, this is how we're going to work together, because you would be less personality disordered. But in the work with the patient with severe personality disorder, there's a lot of emphasis that needs to be placed on the frame setting, that's the setting of the treatment contract. So again, you can see that the usefulness of knowing what is the level of personality organization influences how you clinically approach the patient. So this is going back to just reminding us about the object relations dyad. The object relations dyad is comprised of self-representation, representation of other, bound by an affect. Now, this is where TFP starts becoming dynamic, because you have a self-representation and a representation of other. Now, often our patients, particularly our borderline patients, feel that they are the victim. Their self-representation is they are the victim. Oh, I've had a terrible life. I've been abused. My husband's treating me badly. It's the self-representation of being very, feeling very victimized. And their representation of the other is that the other is the person. My husband is unfair to me. My husband is cruel to me. And you, doctor, are cruel to me as well, because you're not setting aside enough time. You don't see me often enough. So that's their representation of you. Now, no one wants to be in the victim position. No human being wants to be in the victim position. So this is where things become dynamic. By dynamic, I mean there's movement. And the movement is that the individual, the patient, moves from being in the victim role to being the persecutor. So then they start saying things to you like, if you do not do this, then I will complain about you. Or if you don't extend the consultation, I think I'm just going to kill myself. Can you see how they move into being the persecutor? So that's the first dynamic, the reversal of roles. Now, the second dynamic is to think, why is the patient doing this? In other words, what we often with our patients, we are in touch with the surface dyad, but to be aware that because we are very complex, there's not just one dyad at work, there's a deeper dyad. So, for example, the deeper dyad, which again, remember that the dyad is the self and other representation. The deeper dyad might be one which makes the patient feel very vulnerable, and that the surface dyad, the patient being very aggressive, being attacking of you, may be in the service of defending against the more vulnerable dyad. In other words, that they wish that actually you would be a very good carer, a very good doctor for them. And because that makes them more vulnerable, what they're more in touch with is the attack on you. And what you certainly, as the clinician, are more aware of is the attack on you. Now, this is what we're describing as being the typical personality organization of a patient that's borderline, where they have a very split personality organization. So this, I think you would feel familiar with. The patient sees everything in very extreme terms, in very black and white terms. So, for example, on this side, everything is negative, or everything's wonderful, everything is positive. So, you know, in more classical analytic terms, this would be describing what Melanie Klein described as the paranoid schizoid position. Now, I'm moving on to the fact that TFP has a structured approach to wanting to work with personality and personality disorder. Now, and remember that I've said one can think of strategies, one can think of tactics and technique. In terms of strategies, the overall approach is really to make clear to the patient what their main object relations dyads are. That's everything is in the service of helping the patient identify more clearly how they're experiencing themselves and others, so that by having that ability to recognize how they are reading the situation, which may be inaccurate, the theory is that that enables the patient to control more what they do and don't do. So that's the overall strategy. The tactics, in terms of how we try to achieve that, is through clarity about the treatment contract and maintaining the treatment frame. And I'll come back into more detail about that. And the technique, so this is something which Kernberg did, which he said, if you think of all the different analytic techniques, finally, the ones that are the main ones, the ones that you can group a lot of the different, the many, many different analytic techniques is the following. It's use of the transference, use of the counter-transference, a systematic approach to interpretation, and maintaining technical neutrality. I'll come back to what we mean by the 3 channels of communication. So in terms of interpretation, so colleagues, what I'm speaking about now is I'm giving you an overview of transference-focused psychotherapy so that from that you can see what may you be able to apply in your work as psychiatrists. I very much appreciate that not all of this will you be able to apply in a straightforward way in your busy work as psychiatrists, but I'm more wanting to say this is what TFP does so that you can think of the application in your work. So in TFP is very systematic about its approach to interpretation. It doesn't just do wild interpretation. It steps up to interpretation in a very careful way through clarifying, in other words, asking the patient to explain or to clarify more what the situation is. And finally, in the clarification, often there will be a contradiction in what the patient's doing. Patient, for example, might be saying, I really love my husband, and then there's evidence that the patient might have been texting another man with the possibility of an affair. So then one points to the contradiction. In other words, one confronts the patient with the contradiction of what they've said. And I put interpretation into brackets because it's to say that we don't always interpret, and we certainly don't interpret in every session. It's to be used very carefully. Now, the concept of technical neutrality is often misunderstood. And it's often misunderstood for what is an inaccurate understanding of what psychoanalysis is. You know, often people joke about psychoanalysts, oh, they are very stern-faced, they just quiet all the time. Now, that isn't what technical neutrality is. It's not about being indifferent or emotionally distant. What it is, it's about not being drawn into the dynamic of the patient's emotional storm. It's being able to take a perspective on what's happening without getting drawn, for example, into a very strong counter-transference. Easier said than done, and we'll see, you know, in the role play that's very. I mean, and you know from your own experience, gosh, it's very difficult to maintain not too disturbed by the patient's projections into you. Now, this is an important concept because if you think we as doctors are trained to think about what the patient is saying, and we tune into what the patient is saying, we tune so much into what the patient is saying. And if you think about it, a borderline patient says things in a very confusing way. In other words, you're using 99% of your brain to try to understand what is the patient saying. Now, colleagues, what I'm recommending to you is to not do that, because the way that the patient communicates is through their nonverbal and through the countertransference. And once you realize that then the discipline would be to allow yourself to not just focus on the verbal, but to also observe what is the patient doing in their nonverbal, and also what are you feeling, because what you're feeling may be very useful information because the patient is projecting their feelings into you. So it's a very important concept to think about. Are you able to use all 3 channels of communication and not what we as doctors do, which is we always focus on what is the patient saying, what's their verbal. So let's come on to this clinical case now. So this is a 34-year-old female patient being seen in my service. And the presenting complaint is that she has been self-harming. She's got behavior which is very difficult to understand, very chaotic behavior. And in the meeting with you, she says, I want to feel better. I've got a very bad relationship with my husband, and I'm very worried about my children. I want to be a better mother, but I have lots of fights with them. In the past psychiatric history, it's an absolutely classical history that I'm sure that you're familiar with in your work with borderline patients, of lots of visits to primary care, lots of attempts at previous psychological intervention, lots of visits to emergency department, lots of admissions to psychiatric ward. And this is absolutely typical, the number of diagnoses. So this patient has had diagnosis of personality disorder, 4 different diagnoses of personality disorder. She's had diagnosed depression, PTSD, bipolar affective disorder. And she's been on a whole range of psychotropic medication. And in this scenario, we joined 20 minutes into the assessment with her. Now, colleagues, this is a video, but the video isn't playing, which isn't the worst thing, because we're going to have a real live role play. And we save some time, but the bad news is that I'm going to have to act as the patient now. Because what this patient is initially very pleasant with the clinician. But 20 minutes in, there's a sudden switch. Now, I can't do it as well as the actor, but what the actor says, so are you going to help me? Just tell me, I don't have time. The clinician says, but it does take time. And she says, why? Why? I've been pushed around all my life. Clinician says, look, can I just get back to, and she stands up and she says, you know what? You know help at all. You don't know anything and you're a waste of time. She starts, getting all the clothes again. She says, I've got tablets at home and I know what to do. And she starts moving out of the room. Now, I'm sure that that is a situation which all of you have experienced at different times in your psychiatric work so far. And we can imagine that what you're going to feel is you're going to feel anxious, you feel irritated, that you might want to avoid seeing this patient, you might want to deny the emotions you have, you might feel, well, what can I do? In other words, it raises a whole lot of different feelings in us as psychiatrists when our patients might do something like this. And in fact, let's acknowledge that at times you might have such a strong counter-transferential feeling of animosity that it could be accurately described as hate. The patient is being hateful to you, and if you're honest with yourself, you are feeling hatred as well. Of course, I'm not saying that we act out on the hatred, but I'm saying once the hatred is acknowledged, it allows the clinician to not act out. You're just acknowledging, I have a very strong feeling of anger towards the patient at present. So then the question is, how would we apply what we now know about transference-focused psychotherapy to this case study? So we can think of aspects about assessment. And remember, I've said that TFP thinks about strategy, tactics, and technique. So in terms of assessment, what we'd be thinking is, where is this person in terms of their level of personality organization? And we'd be placing at least at a moderate to low level of personality organization. In terms of strategies, remember that I said the main aim in TFP is to think of what are the dyads. So we could think, what's the main dyad which is working in this encounter with the patient? And most importantly, what's the function of the dyad? Might it be serving a defense against a far more vulnerable, deeper dyad? And then also to think how may the use of if there has been any frame set up with the patient, or in any understanding of how you and the patient will work together, how might that help you? And then in terms of technique, use of the four main techniques that Kernberg has recommended. How might technical neutrality help you? How might understanding of the transference help? How might understanding of your countertransference help? So what I've done is I've thought of a way that one can conceptualize managing the encounter in this way is to think of, how children think about ready, steady, and then go. The ready, steady is applying the structural approach to TFP. And the go is that when you start making your response, to do it in a structured way. So the ready, steady, in other words, before you make the intervention, it's just to tolerate being confused. When the patient says, you don't know anything and you're a waste of time, probably your immediate thought is, she's right, I don't have a clue what to do. The patient's going out of the room. My colleagues are going to think that I'm incompetent and the patient's going to kill herself and I'm going to be in the newspaper tomorrow. You might have all those thoughts, yeah? And then you might also get a thought quite soon afterwards of feeling quite angry with the patient. Yeah? The point is just to acknowledge those are the feelings you have and just to tolerate them, that it's to not feel bad about having these feelings. It's more that once one acknowledges these very difficult feelings, these confused feelings, to then try to understand them. Often you're going to feel quite stupid, incompetent, controlled by the patient and angry, and just to accept that's how you feel. Then to start thinking about the dyads. What might the dyad be and what might be the reversal of the dyad be? And then to start thinking, the patient is being very, very attacking of me, but might there be some libidinal or some vulnerable part which he's trying to protect against? Because that allows you to maintain a sense of humanity with the patient. And also to think of what are the different channels of communication. In other words, if you'd seen the video, you would have seen there was one clue earlier on which the clinician missed, that the patient was starting to become very impatient. In other words, if the clinician had been able to detect earlier on from the nonverbal, there's a clue that the assessment is going very, it's becoming very, very difficult. That would have been useful. So what I'm doing here is saying that this is a way that one could try to manage it. And remember that I'm doing this for didactic reasons, that I'm not saying that you as a psychiatrist will be able to get through all these steps. But even if you get to steps 2, that would be good. Yeah? So a way to manage this might be that the psychiatrist might say, please just stay in the room with me and just to see whether what I say might be helpful. And that you could say something like, you started this meeting saying that you're feeling very anxious and nervous, that I wouldn't listen to you. But now you're saying that you think that this is all a waste of time and you want to end it all and you want to kill yourself. Is that correct? Is there something I've missed about what's been happening in our meeting? So you're trying to clarify what's happening for the patient. So if they, still looking at you and they haven't left the room, then you can try moving on to the next step by saying, but by threatening to harm yourself and saying that you don't care what you do, then things seem to have been reversed really. So that now I'm the one that, is anxious for you and that you're the one that's in control and in control of taking your life. When I read about identifying the reversal of diet, I'm not saying, oh, and you reverse the diet. All I'm saying is I'm saying it in ordinary language. This is what the patient has done. This sudden switch in how you feel about yourself and those around you, it really is a problem that you described. And it also affects your relationship with your partner. Now, again, if the patient's still in the room, then you might move on to the next one, which you say that you started off the meeting telling me how long you'd waited for this appointment and that you really were hoping that I would help you. Because you've said it really is important for you to be a good mother. In other words, you're validating what the patient has said. But you may be so scared that such an important thing won't happen that it seems safer to walk out on this. So in other words, that's moving to interpretation and to identify what the defensive diet is. You are doing this because you're protecting yourself against being disappointed. Can you see how I'm trying to move through the different steps to try to manage the situation? And clearly, if the patient still stays in the room, one can move to thinking what might one do in a less heated part of the interaction with the patient. So what I'm proposing from this clinical vignette is that TFP might be useful in terms of its contribution to knowledge, in terms of thinking of which level of personality organization is the patient at, and to start thinking of object relations theory. How does the patient experience herself? She experiences herself as a very unloved, very victimized person. That in terms of helping you with managing your attitudes, it helps you to hopefully tolerate being confused. And when you feel that you're feeling incompetent, stupid, angry, to think actually this is how to understand how the patient's feeling, and she's projecting that feeling into me. And then in terms of skills, how you might recognize what the dyads are, how you might use clarification, confrontation, possibly interpretation, how you might identify the different channels of communication. I don't know how to take this hand down. I can see my hands raised, but I'm sorry that I can't take it down. So there's been a lot in TFP written about the application of TFP in general adult psychiatry. And remember, if we think about it, we as doctors, we as psychiatrists, we're often being asked to medicate our patients. Now, there's no evidence base for the effectiveness of psychotropics in personality disorder. Yet, studies have shown that more than 90% of our patients, borderline patients, are on psychotropics. So why do we use it? And I think part of the reason why we use it is because of the strong pressure that the patients place on us. And that's at least one thing that doctors can do. Now, what we're proposing is that by having TFP skills, one is more able to work in a logical way regarding the use of medication. And that's work that we've been doing in the UK as well. And in the Maudsley guidelines, we are also have a chapter on trying to help psychiatrists to think about their use. And although we haven't said this is TFP, it's very much based on TFP thinking in terms of the use of object relation. So moving towards the end of this, to also acknowledge that TFP is very useful in working with narcissism. And again, we think that because TFP is operationalized, it helps clinicians in the public sector, because our experience has been that even with trainees who haven't had experience in psychotherapy or a lot of experience with narcissism, having an operationalized approach has been helpful. And also just to note that we've also started developing interventions in group TFP. So in terms of training and supervision, there's the applied TFP, which is different to doing a whole TFP training, the psychotherapy training. In terms of applied TFP, we've done similar teaching as we're doing now and shown effectiveness in terms of how the participants have found it's helped in their attitudes and how they feel about their work with borderline personality disorder. And we've also used TFP to train our patients in their psychotherapy long case. And the findings have been positive in that when we asked the trainees how they found it, they've said that it's helped them both to learn how to do psychodynamic psychotherapy, but I think most importantly is that it's had positive effects on their psychiatric practice, that they felt that it's helped them in their day-to-day psychiatric work. So I appreciate we've gone over time now, and I've reached now the end of the lecture part. And so now it's the invitation to put all that I've said to the test, where we can say, well, it's all very easy for Tennyson to say these things, but let's see, how would it actually be put into practice? I'm going to stop sharing now.
Yeah, thank you. That was a very good overview of TFP, and I'm sure that people must have heard it very well. And if there are some questions, we can take it now so that we can take some of the basic questions related to the theoretical aspects before we go to the role play. So if there are any questions, so you want to clear regarding the assessment part or regarding how to apply or any basic about the theory, just feel free to ask. You can turn on your audio and just directly ask, or you can just type in the chat.
Good afternoon, sir. I have a question. In the Panksepp model that you showed, so in that we understand transference to be working at the level of cortical or subcortical emotions. Sorry, subcortical emotions. And but in the imaging study of TFP, you explain that it somehow works at the level of the prefrontal cortex. So could you just clarify that a little bit?
Thanks, Eepsita. So remember that, in fact, we would make the claim that TFP, by working in the transference, is working at the unconscious level, which is subcortical. And what the slide showed, or what the study showed, was that there's downregulation of the limbic system. In other words, what it's saying is that its effect is to help with emotional, with the level. Actually, the claim would be that it actually helps with the neural pathways at a subcortical level as well. That the intervention per se, yeah. Now, that's partly linked to thinking about the understanding of what's the unconscious and what is memory. In other words, that's a longer discussion, that we are saying that by working in the transference, we are helping the patient to rework what is a prediction that they don't even know that they've made. We are helping them to reconsolidate memory. In other words, that we are helping them to go into a different pattern of behavior. Now, although I've said behavior, the behavior is unconscious, so it's not a CBT. It's working at an unconscious level, but that it actually is finally affecting behavior. So I appreciate I've done it. I've responded, I think, in too sort of compressed a way, but I think it's an important question. And I think what we would say is that TFP is really addressing, working also with the unconscious. And I think that it's important to stress that, because, what Cam and I have been wanting to very much say is we very much are respecting all the different modalities of evidence-based treatment. All we're saying is we encourage colleagues to take psychodynamic, psychoanalytic, and TFP seriously, because it's one of the approaches which actually is trying to deal with the unconscious. The other evidence-based approaches are working at different levels of the brain, including mentalization-based treatment, works more, it's less working on the unconscious. That's why we're just saying, gosh, in the same as if we have different antibiotics which work for different kinds of organisms, it's the same. We're just saying TFP adds to the range of instruments we have because it works on the unconscious. And we acknowledge that more than 90% of our actions, of our actions are actually unconscious. We don't even know that we're doing them or why we're doing them. It shows how important it is to have an intervention which is working on the unconscious.
Yeah, well, Prashant, you can ask directly.
Sir, hopefully I'm audible.
Yeah, it's clear.
So often when we encounter patients in the clinical settings, it's often that we take a lot of sessions before we complete the history and then get a complete picture of their personality issues. So often there are these clients who are very difficult right from the start, even before we can come to a conclusion, if at all they have any personality disorder. And a lot of times it ends very prematurely, any kind of proper alliance. So at what time point does the therapeutic framework of TFP comes into place?
That's a fantastic question, because are you saying you're describing your work context as in psychiatry as opposed to psychotherapy? Yeah.
Yes,
Because
sir.
in fact, the question that you've raised is exactly what Cam and I are very interested in, because what I'm saying is it's such a good question. I don't think there's a clear answer to it, which is why I'm going to give my response and then see whether Cam's got an idea as well. The point is that if one's doing a psychotherapy treatment, one then has the luxury of setting up a treatment frame and a treatment contract.
Yeah.
Yeah. Now although I'm saying it's a luxury, it's very difficult. So within my service, we spend many meetings establishing that. Yeah. So that's difficult in itself, which shows why your question is such an important one, because then we're saying, oh, but Tennyson and Cam don't come to us as psychotherapists, come to us as psychiatrists. What do we do in our busy psychiatric setting? I think that might be what you are saying. Yeah.
Yeah.
Yeah. Now, the point that I would make is when I've consulted with general adult psychiatrists, I feel that they have no adequate protection of themselves because they don't apply enough of a frame themselves. Can you see my point? That there are some psychiatrists that will not ever feel there's a limit to their ability to prevent a patient from taking their life, and they'll make large attempts to keep on doing something. What I'm saying is, I think the question that you're raising is a very important one, because it's what might be the limits or the frame that the psychiatrist sets even internally in their own thought, so that when they meet the patient that makes very high demands, they already know what their limits are, and they don't say in a punishment way, oh, I can't do that, patient, but they say in a kindly way, what you're asking for is, I understand, because you really want to, to get proper treatment.
Okay.
However, in terms of how my outpatient is structured, I can only see you for 30 minutes. You see,
Okay.
I think it's more GPs than psychiatrists. Like, no, that's fine. I'll see you for an hour. They haven't kept the frame themselves. Yeah. But I think yours is a very important question, because I do think that that Cam and I aren't one to say, oh, let's bring in all the luxury of psychotherapy thinking and say that it can just be translated. I think that what you've said is very much what we would like possibly to work on with your group. How do we translate some of the principles into what might be useful in busy psychiatry? Does that make sense? I think
Yes,
I'm really
sir.
glad you asked
Yeah.
that question.
Yes, sir.
Cam, I'm not sure whether you wanted to add to that,
I'm
because
happy
it's a
to.
really,
Yeah. It's a really important question. So I'm reminded of working with trainees in psychiatry whilst they're doing some psychotherapy training with me, and struggling between the frame shifts they have to make in the two settings, the context being different, the pressures, the timelines, the unintended consequences, and the way that psychotherapy requires a courage to cope and bear uncertainty and hold the frame and not act sometimes, whereas in emergency services or in acute psychiatry, you have a tendency to want to act, to be in charge and control and make decisions in a technical, algorithmic way with more imagined certainty about the outcome than there really is much of the time. So there's a very two different frames that you're working with. And what the psychotherapy training allows the psychiatrist to do is to keep in mind that other frame, and to some extent in psychiatry, consider to what extent you can shift within your context. So if it's in A&E, and Tennyson's description of the patient wanting to leave and take tablets, that's a very, very common scenario. And in that moment, it's very hard to be aware of the projection. I was going to send a comment actually in the chat. To be aware of why you feel so terrible that you failed the patient, they're going to kill themselves, how terrified you are. It's difficult to know that actually you are not so terrible. And in that moment, you feel awful. You are terrible. You're the worst person there is, and you're abusing the patient, and the patient is saying, and you believe them because in that moment, that projection is so powerful. And what psychotherapy training allows you to do is to recognize that and to pause and say, that isn't me. That doesn't feel like me. That's something else. That's somebody else. That's something from the patient that I'm holding for them. And even in an acute setting, it allows you to think differently. So some GPs who are dynamically trained are very good at this, and psychiatrists are very good at this. But it does mean your environment has to be different, and also your own self-care and the need for supervision. It has to be explicit. But it is possible to do, it is possible to enhance, but within those constraints that you're working within, and also the extent to which I think Tennyson's outlined the patient in that moment. If you're both in a crisis and you both have very activated amygdala and limbic systems and you're not thinking cognitively, it's a problem. Neither of you are in the best place. So that's the one thing that psychoanalytic work allows you to do, is to pause and say, I know this place. It also leads to the earlier question, actually, which is very, very important as well, about at what level does all this stuff work. Honestly, the brain is so complex. We think we know, and we're having to work it out all the time. So we know that prefrontal stimulation introduces top-down regulation of subcortical activity. And there is an honest disagreement between cognitive neurosciences and affective neuroscientists. In fact, there's a paper from 2017 that Pankset's written where he maps agreement and disagreement between those two groups, and about where consciousness happens, to what extent it's possible. Does it happen? Is all affect linked to cognitive appraisal, or can it be subcortical without cognition at all? And there's some frank disagreements. So what we need to do is do more elegant experiments to look at how TFP can impact on plasticity and on functioning. But we may disagree markedly about those things, yet that we get closer with each step to doing that. We know mindfulness, for example, mentalization has an effect on cognition and brain plasticity as well. All of those things are coming to the fore. So we are very young, really, in the science of this activity, and to have options is very important. But clinically, to be equipped, to have extra tools that you can apply, and the tools in this instance, what's difficult in psychiatry is you are the tool. You have to look after yourself and be sharp and be balanced and caring for yourself, which isn't easy when you're working in a busy service, and you're rushing around and life isn't great at various times. I hope that captures some of the issues for you. Tennyson, I'm going to have to leave, I'm afraid. I'm really sad to leave, colleagues. So have a lovely rest of the session. But that was a fabulous start, and I really enjoyed that, and some really important questions coming up. And Debasish, bye-bye.
So we go ahead because otherwise we will be running short of time. So we go towards the next session, in which we will be having a role play session, and after that, we'll be having a debriefing. So I will be just reading.
So, Najit, may I suggest something?
Yeah, sure.
I think it'd be good, including my own need, just to have a short break.
Yeah, sure.
Um,
So,
and then you can set out the scene so that everyone comes, when they come back, then you've set out the scene, that it'd be fresh in their minds. If you
yeah,
set out the scene, we go straight into it. Is that okay?
yeah, it's okay, perfectly okay. Let me know when you are ready to join.
So should we just agree that we have we got, are we ending in what's UK time, 12:30, your time? We're ending in just about under an hour's time. Is that correct?
Uh,
Yeah.
yeah.
Yeah. So let's take let's start at 15 minutes to the hour. So that's about 8 minutes break. And then we have 45 minutes. Is that okay?
Yeah. So you will join after 8 minutes?
Yes. So at 15 minutes to the hour.
Yeah, sure.
So everyone can just get a refreshment, and we'll join at 15 minutes. We'll restart at 15 minutes to the hour.
We will keep the link open. You can
Sure.
join, sir. We are
Sure.
already joined, so we don't log out.
Yeah.
We will wait
Okay.
for you. Thank you.
See you all shortly. I hope that we can, get onto the important things that you do want to talk about. Before we start, can I just ask how you would like me to call you?
What do you mean by that?
Should I address you as Miss Nina or Nina? How would you like me to call you?
Nina is fine.
Okay. So Nina, I'm glad to be able to meet. Just again, I'm Dr. Lee, and I'm one of the psychiatrists working in outpatients, and I'm glad that I can meet with you now. Yeah. Can you tell me what would be the most, first of all, just to say that we've got half an hour for this meeting. What would be the most helpful that we can think about, given that it's not a long time?
Well, I don't know. I have been through this such consultation so many times, but
Mm,
it doesn't really seem to help me.
mm.
So whatever you want to do for the next half an hour is fine because I don't think it's going to help me in any case.
Look, then I very much appreciate that you even come to speak to me. If you feel it's not going to be helpful, then the fact that you've come and are speaking, I appreciate that. Yeah.
Okay. So what I don't know. I mean, uh, I just keep finding myself in the same situation over and over again, and frankly, it's
Mm,
starting to become a little funny at this point.
mm,
Uh, I I honestly don't know what to talk about. I mean,
mm,
it's not me. People in my life, they drive me to do this. They anger me and irritate me to the point
mm,
where I don't have any other option. And
mm,
then it's me who ends up in this situation and not them.
mm,
So how, it's like I suffer them, and then I
mm,
suffer this,
mm,
and then I have to wait and then I have to waste my time waiting,
mm,
and then I go through these consultations and they're absolutely useless. So
mm,
if any of this was working, I mean, why would I find myself here for the fourth time?
mm. Well, again, I think I understand what you are saying, and in a way, I think to say that I will try to understand what's happening now, but we may not be able to sort it out within this first meeting with you. I hope that we can at least get to some place where we can continue thinking together.
Maybe, fine. I mean, that really depends on how this meeting goes. I can't say right now.
Fair enough. And that's. Can I ask? I'm aware from the notes that I read before coming to meet with you that you were admitted because you'd taken an overdose, and I think it's because of difficulties in the relationship with your boyfriend. Is that correct?
That really depends what you mean by difficulties in the relationship. What would you
Yeah. Well,
say difficulties are?
you see, I was going to ask whether we can think about that because, but I first wanted to ask, is it okay that we think about that? Because I appreciate me going into very personal things very quickly. Is it okay? But it might help me because we have limited time, just to understand the most important things, if we can go into that.
Yeah, that's fine. I mean, because by this point, my personal life is an open book for all your doctors to read. So I don't see how you going into the personal stuff would affect me or help me. I mean, can you really call it relationship difficulties if it's one person who's causing all the trouble all the time, and that's him?
Can you tell me a bit more about that?
He's so unpredictable. I never know what he's going to do. I don't know how he's going to react. And he'll just lose his mind over the smallest of things. And I understand I can be a little difficult at times, but he signed up for this, and it's not like I forced him to be in a relationship with me. He signed up for this. And uh he's so unpredictable. He just leave without telling me. And when I tell him that I'm angry, or I because of course I'm human, it'll make things he does make me angry, and then I lose my temper. And then he'll pin it on me that I'm the one who's behaving erratically.
Look, you're saying very important things. Now, can I just ask you something which I want to understand? Is it correct that your boyfriend brought you to the emergency department?
Yeah, he kind of had to.
Well, he had to because why?
Well, I assume that's the least he could do after being the root cause of everything.
Well, that's what I'm trying to work out, whether it's, I don't know, that's why, because I don't know about the relation. But did he bring you because he was also concerned about you and that's why he brought you, or did he bring you just because he felt annoyed with you and that's the only thing that he could do? I mean, how do you understand it?
I really don't know. I don't think I understand him anymore, and
Okay.
I think I was a fool to even imagine that I ever understood him, apparently, because yeah, maybe you should ask him instead of me.
Well, given that he's not in the room, all I'm saying is that you're not sure at present whether he brought you because he was just annoyed and he was wanting someone else to take care for you, or that you're not sure whether in fact he might have been worried about you.
I guess it's possible that he was worried, but uh, it's really childish of him. I mean, first you cause all the mess, and then once the inevitable consequences happen, which is me getting upset and doing this, then you're worried and then you're scared. So yeah, I mean, maybe he was worried, but that's his fault. That's not my fault.
Can you tell me what, again, I appreciate that this is very hot stuff, but can you tell me what was the lead up, the thing that he did that made you upset?
I'd asked him to go to the grocery store and get some things.
Mm.
I made a list and I gave it to him. And I needed red wine to cook with. And I told him I'd been building up to it all week that, I'm going to cook for us on the weekend. And I don't know, I think one of his friends called and he got distracted. And even though I put it on the list and I underlined it, he still didn't get it. And then he came home and I was really mad at him. I was like, I told you I was going to be cooking. I told you we were going to do something nice this weekend. And you still didn't bring it. That, it just shows how little you care for me. You can't even do one small tiny thing. And then he got upset and he stormed out of the house. And I kept trying to call him and he wouldn't answer. And I sent him text after text and he wouldn't answer. And I left him voicemail after voicemail and he would not get back to me. And this went on for an hour. And then I just broke down, I didn't know what to do. And I was just so angry at him and I was just so angry at myself for, just ending up in the same situation with him over and over again that I don't know. I just lost control of myself.
Thanks. I mean, that really does help me to understand what happened. What I'm also thinking is that cooking this meal and having a pleasant evening with him was very important for you.
Yes, it was, of course.
And that, that you were understandably very disappointed that he'd forgotten an important ingredient because you were looking forward to the evening.
Yeah. No, and it's not just about that. I think it's about what it means. I think if you really cared about somebody, you would not forget stuff like that.
Yeah, I mean, it makes sense that what you're saying is that you felt that because he forgot, for you, it meant that he wasn't really caring for enough or wasn't committed enough.
Yes.
I mean,
That's how I
seems
felt. And I told him that this is how I feel. And he says I'm crazy for feeling this way, that I'm always blowing things out of proportion. But I don't think I don't think that's the case. I think he says that to me because I actually see through him.
I mean, again, what I'm just thinking is that a way that we can understand why you were so angry is because you felt so disappointed about not having had, what you'd planned. You'd put a lot of work into a good evening meal, and you felt that he hadn't done his bit in a way.
Yeah, I think that that's correct.
Now, you see, I would like, and I appreciate that there may not be enough time in this meeting, but I think we're saying something very important, that in a way, sometimes when you respond very strongly, it's because you actually want things to be really good between you and your partner. That's what I'm understanding.
Yeah, that's absolutely correct. And I mean, I think you're the only one who's ever put it like that. And I'd really appreciate it if you would convey that to him, that I'm not crazy. I feel very strongly, and perhaps that's why sometimes emotions get the better of me.
Yeah. Well, in a way, what you are saying is, if you put a lot of thought into a pleasant evening, that you get very disappointed when it doesn't work out. That's what I'm understanding you saying. And what you are saying is that you feel at times he doesn't quite get it.
Yes.
Hmm. So I think what you've said now is very, very important. And because I'm seeing you in emergency department, what I'd like to do is, because I won't be the psychiatrist that will see you, as a follow-up, would it be all right with you that I discuss this meeting? Because I think you said something very, very important to my colleague who will be seeing you in follow-up.
You want, yeah, I mean, it's okay if you want to discuss it, but why do you want to discuss it? What's the point?
Well, you see, I think that maybe what's happened so far is that there's been the focus on when you feel so disappointed, there's been a focus on the argument or that you overdose. And I think that what would be important is that's so important, but that to think about what might have happened before, which also led to that. And I don't want us to lose that, because you said something very important now.
Yeah, I mean, it doesn't matter if I say a lot of important stuff. He's the one that needs treatment, not me.
Well, would you be willing to think about that? I mean, what we might also need, and that's why I want to discuss it with my colleague. But again, what you feeling is very, very important. It may be helpful to think with your partner as well. In other words, to have both of you in the room. Is it something that you would consider? And it's not as though it's the next time with my consultant colleague, but that you would at some point think that you'd ask your partner to also meet with us, so we can just think together, all three, or you, the doctor, and your partner.
Yes, I can ask him to meet, but I don't know if he'll agree, because he always tells me that, I'm blaming him for everything, and he's scared that the doctor is going to give him a talking down to, which frankly I think he deserves. But fine, okay, I'll talk to him.
Sure. So that's very helpful, because then I'll say to my colleague that it's an invitation to your partner. Of course, he doesn't have to come, but if you could also, you see, my thinking is that by having you and your partner in the room, it helps us to better understand what's happening, but also that he may say things which help us to understand you better, and you may say things which help us that help him to understand better what's happening. That's why it might be useful to have both of you in the room. But what you need to say if you invite him is, he's not the patient. You're the person that we wanted to see whether we can do anything which is helpful, and he's just coming to help us to think, really.
Yeah, I think we could do that. I'll talk to him.
So I think we're going to let's end role play now, because clearly there would be other tasks to do, but I just want to give some sense of how to approach it. So shall we end now? And then Swapna, do you want to come in to take over the chair again?
Oh, sir. Yeah, carry on, sir. It was a nice, interesting one. And the role play was very good. So any questions what anybody wants to ask, or what you have in mind, how to debrief?
So
from starting from the initial sentences towards the middle, then towards the termination of the therapy session.
What might be a way to do it is to initially ask Eepsita just what her initial thoughts are, and then maybe to take questions from the group. And if Sita, again, you might have particular responses in terms of what the group says. And then I can say what my overall strategy and what I was thinking at the different times were. Does that make sense? That so, Eepsita, do you want to, if that makes sense to you, and if you feel okay about it, first of all, let's derail to say, Eepsita, thank you very much, colleague, for role playing the patient so well. So thank you for doing that and for making me sweat. Thanks for doing that. So we should always derail. So maybe if you're okay to come in, just say whatever comes into your mind. Yeah.
Right. So, sir, I think a few of my takeaways were as as the patient, when I think at some point I did feel like because there was no, despite how I was getting angry and kind of agitated, there was no change in your stance or the way you were speaking to me. I think I felt reassured after a few questions as the patient that okay, this is a safe space, which is why towards the end I felt like I really don't have any more room for disagreement. I have to agree. And uh, I think as a psychiatrist, I appreciated how, while there were some very difficult questions, and clearly, the patient was trying to kind of suck you in to her relationship dynamics or her warped way of thinking or whatever, you address that question and you kind of shelved it that okay, yes, I've heard you, I understand you, but you stayed focused. I mean, you did not let it derail the conversation, which is, I think, what happens with a lot of us quite commonly. The whole conversation gets derailed completely, and we lose sight of what we are trying to achieve with the patient. So yes, I think off the top of my head, this is what I'd say.
Another thing I would like to highlight to the group is that this was not a drafted session. It was completely impromptu, and this question and answer, these were not transcripted. So whatever came to the mind of the patient and doctor, they actually played in the same sense by going into the actual role play session. Another thing which we often see if you read all the books or the chapters of the conversation in the textbook of the Western countries, here the actual scenarios in which the patient are slightly different from the Indian context, because here the Indian patient usually are not so rude to the patient. What we feel rude in some of the scenarios we have seen, because we have seen the patient may not be uh, greeting, or patient may not be answering well. And like in the scenario you discussed today in the session, that the directly walked towards the door. So that usually we don't see. Patient may get angry, may refuse to talk, may cry, or may not come in the next follow-up. That's different. But usually in the session, we don't see that the patient often trying to in borderline patient, because that we see a slightly change in our scenario. I don't know. My other colleagues might be who are well experienced. They might say some other points. Thank you.
So, Najit, can I just come in on? It's a very interesting point that you've made, because what I'm saying is, the technical point is, if I parachuted into Chandigarh on Monday, and you said to me, Tennyson, we need a psychiatrist to work in outpatients a day, please just go. And so say I was the psychiatrist on Monday. If I don't realize that actually the patient is being very, very rude to me because they are politer than in London, I might not be getting all the communication. Can you see the point about it? So it's very important that, in a way, some of the cultural manifestation of the interaction might be missed if I'm not picking it up. In other words, I need to know if the patient's being very, very rude to me, so that not that I act out on it, but I understand this patient's feeling very strongly that maybe the reason why they're being so rude. But if I think, oh, they're just being polite, I might miss that. So it's a really important point.
Yes, sir, I agree. That has been my experience also, what Dr. Sapanjit has said. Uh, I mean, I think because of the cultural factors in play, we see patients, we don't see patients being very overtly aggressive or rude, especially during the first few interactions. That may come up later on, and I mean, of course, unless the patient is extremely disturbed or the personality disorder is quite severe.
You see, in a way, and it brings in the thought about what the research aspect to this is, because if we accept, say, the thinking from Panksepp and others, that the way that the mammalian brain is engineered is the same for us all. We all have these different emotional needs as human beings. Then it might be saying, how might they manifest a bit differently? Manifest, but the needs are still the same. Can you see what I'm saying is, I don't think that I'm just thinking of what you're saying, that I don't think we would say that someone is less aggressive in one culture. It might be that the manifestation of the aggression is far more nuanced and far more sophisticated. I'm just trying to pull to the biology and then the cultural aspects of how we're working, really.
Okay, I would like to ask the residents if they can ask any questions directly to Dr. Tennyson regarding any doubts or how the session went, what are their views, what they could understood. So anybody, just switch on your audio, video, and just ask. Silence. So other people can also ask, the seniors and faculty members.
Yeah, I think just to get the ball rolling until other people might think of a question. I was just wondering, did we also have an inkling of the transference process that you're talking about, or is it still a bit late to come up? Would you like to comment upon that in this snippet that we saw? Sure. Is it possible that it might come up right in the beginning? Thank you.
So, you see, a way that we would think is that the transference is always there, whether it's in a psychotherapy session or with the psychiatrist, it's always there, because that's, I think, how we as humans are engineered, that we always have an inner template and we always have a prediction about what's going to happen. That's just how we are. So I think it's a really useful question to think about, because what I'm thinking, you see, the patient gives me a lot of material. She says, it's not going to work. Life is very bad. I've been here so many times. What are you going to do to help me? It's my husband. Can you see? But she said, I think she's giving me a lot of information that the self-representation is that she's the victim, that she's very badly done to. And also that she doesn't have agency, that she can't control things. I've got all of that information as a self-representation just from what she said. Yeah. And then I experience how she relates to me, which is saying, well, what are you going to do? What do you want to talk about? In other words, I'm feeling a bit controlled by her. Yeah. Can you see that there's a lot of dynamic already happening? But I don't go into making an interpretation, because I see there's no point in making an interpretation. Can you see that part of TFP is it's very systematic about its interventions. It doesn't just go, even if there's an understanding on the clinician's part, the clinician would think, what's the correct timing? So all I'm using that information for is I'm feeling, oh gosh, I'm feeling that she's saying, so what are you going to do to help me? I'm feeling quite pressurized as a psychiatrist. And I'm just acknowledging I'm feeling quite pressurized. I'm not quite sure what to ask next. And then to think,
Sure. Oh, yeah. Mm-hmm.
And to use all of that feeling of feeling a bit uncomfortable, feeling a bit uncertain, to think this is what the patient's feeling and what she's projecting into me. So I think it's a great question that you're asking, because I think it points to one can start thinking in this way even before you see the patient. One can start imagining what's the patient feeling or thinking. And then you go in, and I already got information that she's that to me is trying to take control. She's saying to me, I'm not interested in you, doctor. You're going to have to show that you're good for me to become interested in you. She's giving me a lot of information from the non-verbal already. Can you see how there's so much information which the patient's transmitting in this way? So, but I think it's a really important question, because it shows how one can start thinking in a way where if we just have a bit of time as psychiatrists just to think a bit about the situation, I think we've got a lot of data. I think we don't always use the data. That's the point.
Yeah, thank you very much. Yeah, I think that was very useful indeed, because I thought since the focus is on transference, why not try to talk about it right from the very first session? And as you say, that there are elements of transference. If we are open to the communication, then we can actually. Swapnajit, I can see a couple of, I think there's one hands up from Vel Prasant and maybe a comment.
Yeah, we'll come to Vel Prasant, seniors, so we'll go to the juniors first. So two of the junior residents, they have asked, I think, a similar question. Both have similar question. One has asked how to navigate further if the patient totally refuses to engage in the interview. Another is that what to do if the patient is guarded, it's not speaking. So both have similar situation. If somebody is refusing and somebody stays for the silence.
Those are really good questions. So thanks, colleagues, for asking those questions. I think the first thing is, if the patient refuses, to not get too upset about it. In other words, it goes back to the technical neutrality. Yeah. Now, remember that, that I said that technical neutrality isn't like me saying, it's not being impassive and not interested. I remain interested, but I do not lean too much towards the patient, nor do I lean too much back. I stay neutral. Yeah. So I would, in a way which is, I would try to say, look, I appreciate, say, for example, Eepsita in the role of the patient had either started the session not speaking, or in the course of it, she'd said, I'm not going to speak anymore. I would make attempts. I would say, look, I very much appreciate how difficult things have been, to the extent where you took the overdose. And I appreciate that you might feel it's a complete waste of time to meet with me. And all of it is so understandable. But we do have 20 minutes left. And my intention is to see whether I can help you. So while we can sit and wait in silence, I think it would be more helpful if you could just say what's happening for you. Can you see in that way, when I say I appreciate that you might think that I might not be helpful, that is an analyst-centered interpretation. It's saying, look, patient, I realize how you might be experiencing me. And that, when one makes an analyst-centered interpretation, it may help the patient to feel understood. And if they feel understood, they will lower their defenses. Yeah. I also, you can see that I'm not being so neutral that I don't say, I would like to see whether we, I can use the time helpfully with you. So I'm losing my neutrality, but maintaining one's neutrality isn't a holy grail. As long as one knows that the aim is to stay neutral and not be too moved around by the patient's projections. I'm willing to say, look, my intention is to see whether I can help you. Yeah? I'm not saying, look, I want to help you. In other words, I need to watch my counter-transference so that I'm saying it in a way which the patient is able to believe or has the possibility of believing I'm trying to be helpful. What I also am saying is we have got 20 minutes. So I'm stating reality as well. Can you see how in that response, I'm doing a number of things. I'm stating reality. I'm stating the constraints of the meeting. I'm doing an analyst-centered interpretation. And I'm also losing my neutrality a bit by saying, but I would like to help you and I would like to see whether we can use the time. So, but I think those are all really good questions. The patient, after all of that, might still stay silent. I would wait a bit and then try again. But when I'm saying, you see, I'm saying wait a bit because I think as clinicians, we become very anxious and then we start talking a lot. So I think it's when you wait, it's not a punishing silence. It's just waiting to see whether you can think of something useful to say. But you can only do that if you're not feeling too pressurized yourself. You're not feeling, oh, I, psychiatrist, am managing this really badly. What should I say? What should I say? Then you're not going to be able to say the helpful thing. Yeah? So it's just waiting a bit. Yeah? I don't know whether, I mean, those are such good questions. I don't know whether those colleagues that asked that question want to follow it up because.
Thank you. Thank you. And Dr. Velprasad, you can directly ask.
So my question is on the other end of the spectrum here. Often our patients come from backgrounds where we see doctors as a higher authority. There's a lot of paternalism in the way the practice sometimes takes over.
Yeah.
So there has been sessions where patients have, even in the first instance, they've asked me to make a promise. I don't think there is anyone else, and it's almost like a trap. They want you to give assurance that you'll be there for them no matter what. They want you to give assurance that you're going to be ensuring that you'll be with them through and through. And they don't ask you to make promises. And I, for once, tried to be brutally honest and said that I'm sure I'm going to try my best, but I cannot make promises. But I have found that sometimes that leads to the patient becoming little guarded after that point of time.
Yeah.
So how do I handle this situation?
That's a very good point because, again, you can see that in the role play with Eepsita, I didn't want to make it fairy tale because I do realize that as a psychiatrist, I might not be the follow-up in the community. Yeah. So I'm stating reality by doing that. And I think that when the patient says to you, will you be my psychiatrist forever? That I think it is very important that we say what's truthful to the patient. Yeah. I think it's so important that we do that we do that even if it affects how the patient feels about us. What I would say is, so I would say something like, look, I very much appreciate that after meeting me for 10 minutes, you are wanting me to promise to see you again. And it makes so much sense because then you don't have to repeat the same story and you feel that you can trust me more by seeing me again. So I very much understand why you're asking that. However, I need to say that in terms of how the service works, I cannot promise that. And in fact, it's probably not likely that I will. What I will say to you is that I'm going to document so fully the notes that you've said that my colleague who sees you, at least even though it's not the same as me seeing you, will have the information. Can you see how I do, again, a therapist-centered analysis? I know how important it is for you. Yeah, I'm saying, and reality, and I'm also as a fellow human being saying, and I understand why you want to see the same person. It makes sense. So I'm saying all of that to try to keep the alliance with the patient.
Yeah.
And then I say, and I think it might be, I don't think it's acting out when I say, this is what I am going to do. I am going to document. Then at least the patient knows they're with a doctor that is taking the job seriously. Can you see how?
Yes.
But I think it's a very important point that you're raising. So that we always have to. I think that the technical theoretical point is to not allow our countertransference, which might be our own contribution of wanting to be the super doctor that can help every patient, or the countertransference of what's been projected into us. Oh, you are my savior. Thank heavens. You're the first doctor that understands me. I want to see you again. To let neither of those affect our contact with reality and to model that reality to the patient, but in a tactful way, to understand why they've made that request. I think it's the same as when our children ask us, Daddy, can I, and you understand why the child's asked that,
Yeah.
but you
Yeah.
can't do it. It's that response in a way.
That makes a lot of sense, sir. Yeah. Thank you.
Yeah, so thank you. It was quite insightful. Now I would like to ask some of the senior members if they can give their views about this session and today's workshop. We have our faculty members here, Dr. Ritu Nehra, Dr. Devendra Rana, and Dr. Salini. If any of them can give some inputs or views.
Uh, Good evening, sir.
Yeah.
It was a lot informative, and it's been a very learning exercise for me. Both the lecture as well as the role play that was done. Uh, I could see that initially I was wondering transference focused, as in you would use the interpretation with the patient. Rather, you have actually used it to understand the patient, but you had done more of affect focused, emotion focused work. And that was really a learning point for me. Thank you, sir.
Yeah. Okay, so I hand over to Dr. Basu. Basu, sir, would you like to say something?
I think this is the beginning. This was quite a fascinating, very informative and exciting format. We all learned a lot, really, Tennyson. I don't know how to, and we're actually now, you have increased the appetite for the next session, which is supposed to be, when is next Saturday, right? That's
Yes.
on 20th of April. And I don't know the agenda of that part, but I understand or I assume that it'll be a takeoff from here and getting into more of the logistics and nitty-gritties. All I can say is that we are very grateful to all of you, and we look forward to not just the next session, but also hopefully a kind of a follow on from here with the PGI Chandigarh group and yours in terms of research as well as service. I can pledge my interest and intent for that as a team leader, because there are excellent people, as you can see, in our faculty and the senior and the residents to take on the work from that. Thank you very much.
Thank you, sir. So let me set the agenda for the next session. And in next workshop, day 2, we will be having a brief recap of the theory, what we learned today. Then we will be having a role play and debriefing session initially, because we want to know what happens in the next session, whether the patient followed up or what all issues he came in the next session and how actually this transference worked. And then we'll be again discussing some of the clinical material and summarize, and then we'll have a post-workshop questionnaire. So those are the next agenda of the next session roughly. So over to you, sir, if you have any concluding remarks. And thank you so much for today's session. And I would also like to thank Professor Kamaldeep Bhui sir, who joined so long with us, and he gave his inputs also. And thank you, Dr. Tennyson, for taking all the hard work for educating our residents, initiating this session. Anything from you, sir?
Thanks very much. Just one thing just to pull up from the vignette, and that is, remember that I said to the patient, can you just help me to understand, did your boyfriend bring you to emergency department? What I'm saying is, you can see that I'm modeling a commonsensical approach to think of what might be happening. And I'm not saying, oh, that's evidence that he cares for you. I don't know, but I'm trying to shake the patient's beliefs just by asking things. I'm not pushing anything. Can you see? So I'm just saying that was something that I tried. It was a risky one because the patient, so why do you ask that? But I did ask that, yeah. So I just wanted that we don't lose the fact that we are commonsensical clinicians that can think of what's the important question to ask, yeah. So just wanted to say that, but also to thank Eepsita. Thank you very much for role play. I think that you're helping us to have a better teaching session just by the quality that you brought into being that difficult patient. And to thank you very much, Majid and Debashish, for all the organizing. And I very much look forward to meeting with the group again next week.
So I once again thank you all for your active participation, and thank you, Eepsita, for doing the role play. Thank you. Thank you, everybody.
Thank you, sir.
We hope to meet you again next week. Thank you.